know, the goal of this is to get some input from the group. So I'll let you go ahead.
This would just be a very rapid, quick run through, but we just wanted to present the work that the group's been doing on tethered cord common data equivalent of CDEs. And the group is, go back please, Dr. Batzdorf, Dr. Caitlin has been very helpful. Holly Gilmer, Dave Gordon, Rupindra Singh, John Heiss, myself, Petra Klinge, Miles Koby, Donlan Long, Malini Narayanan, Dorothy has been very helpful, and Rupindra, as I've mentioned. Next, please. And also Paolo. Next. Now, as by way of background, we thought that these CDEs were important because of some of the controversy that's sprung up over tethered cord syndrome. When Jerry Oakes and Darrell Water presented their series in 1993 of 73 patients, they found that 18% had the conus in the normal position. Next. And the following year, they compared the tethered cord syndrome in the normal position with tethered cord syndrome and the low-lying conus, and they found no difference between the groups. So Oakes and Waters said, well, the occult tethered cord syndrome is really just a subset of the normal tethered cord syndrome. McClone said indications for surgery appear to be the same for both groups of children, less the radiological ones, obviously. And Harold Hoffman, go back, please. Harold Hoffman said that this demonstrated that patients with traditional clinical findings of a tethered spinal cord can have a conus in the normal position. Next. Steinbach did a prospective study and found that 88% of patients with occult tethered cord improved with surgery. 29% of patients improved without surgery, and 12.5% worsened with surgery. He reviewed 13 publications of about 300 patients, and 78% improved after surgery, 3.3% deteriorated, and 3 to 8% recurred. Next.
LOL, period. Not a math expert, but I think those percentages.
Okay, I'm unmuted, right? Okay, can you hear me, Caitlin?
Yes, you're all set.
Yes.
Okay, all right.
I can hear you.
Yeah, good, thank you. So, but there's a great deal of uncertainty about occult tethered cord. So, presenting at the pediatric section of the AANS, Steinbach showed a picture of a conus at the normal level with a fatty phylum, and asked how many people would perform a sectioning of the phylum, an untethering of the cord, and 67% said they would. On the right, there's a fatty phylum. Sorry, on the right there was a conus at the normal position with a terminal syrinx, and only 38% agreed with untethering. And so next. He felt that within the pediatric neurosurgery community, there's a great deal of uncertainty whether or not to perform this surgery on a normal position conus. And he called this a clinical equipoise, justifying a randomized clinical study. Next. And next. So shortly afterward, Jim Drake, I think justifiably came out with the following criticism of occult tethered cord syndrome, saying it has an unclear definition, and after all, back pain and urinary incontinence are very common. Foot deformities, calf atrophy, reflex loss are not necessarily correlated. There's no clear or minimum constellation of symptoms. The radiological findings were not even correlating with neurological findings. The natural history was unknown. The pathophysiology is speculative. bladder dysfunction and urodynamics were all over the page. There's no validated outcome criteria. So I thought that was actually, they're all very reasonable criticisms. And that prompted precipitously, just 13 years later, our engaging this problem with the common data equivalence. Next, I'm just going to turn my light on. So the next. So for those who are not familiar with the CDEs, oh, sorry, go back. It's a common language to improve understanding, analysis, data sharing, and it was set up by the NIH, NINDS, and they've now established these CDEs for spinal cord injury, brain injury, ALS, and a number of other disorders, including Chiari malformation. And they've now recognized the importance of doing these CDEs for tethered cord syndrome. So the goal is to disseminate appropriate standards of data collection, the right tools, and that provides us the ability to focus and simplify data collection and or improve the data quality and reduce cost. Next. So members of the Chiari Stringomyelia Foundation established 7 domains that we needed to investigate: the clinical findings, radiological findings, urological findings, pathophysiology, differential diagnosis, outcome measures, and treatment. Next. So for those of you who are not familiar with the CDEs, the core CDE is a data element that's strongly, imperatively encouraged for all studies pertaining to tethered cord syndrome or whatever particular area, so that there's consistent, reliable, and simplified data. The classification number 2 is supplemental, and that's a much greater number of CDEs, and that the use of those depends on the particular design of the project, what you're looking for, and which CDEs will be helpful for that. And within the supplemental classification, there's supplemental highly recommended. And the third classification is exploratory, and these are items that have not been validated yet. Next. So next, clinical findings. And Holly Gilmer is going to discuss some of these core findings for tethered cord, including the cutaneous stigmata. Holly, do you want to take it?
Sure. Thank you. So, we've talked some about, Dr. Henderson has mentioned already some of the, known findings with tethered cord, some of the presentation with back pain, lower extremity weakness, gait changes, sensory deficits. Patients can be hyporeflexic or hyperreflexic with increased or decreased tone. And then, of course, bowel and bladder dysfunction, change in urodynamics, and frequent UTIs that we'll talk about later. We may have masses, and then neurocutaneous signs and orthopedic findings. Those have been pretty much already covered in the previous CDE. So I'm going to talk some about the cutaneous and orthopedic signs. So the first that we thought should be a core recommendation is the deviation of the gluteal cleft or abnormality of the gluteal cleft. As we know, it can be either midline or it can be bifid, but you shouldn't have one limb much longer than the other. We decided this should be a cutaneous finding. You could argue that this may be an actual subcutaneous lipoma shifting the cleft, or an abnormal angulation of the sacrum due to scoliosis, but we left it as a cutaneous finding. Next. Meningocele, as you see in this child. Next. Sacral dimple can be obvious like this, very, very abnormal, or it can just be a sacral pit. This should actually be hemangioma, not sacral dimple. And you just see this small dot. Well, can we go? Yeah, there. And so you just see this small dot here. Next. So this child had open spina bifida that you see below, but higher, the tuft of hair, and deep to that, she had a split cord malformation with tethering at that site as well. Next. This child is actually showing us several findings. We included this picture for the hairy patch, but he also had a thickened meningocele above, and below he has an abnormal gluteal cleft as well. For spina bifida occulta, we felt this should be a core criteria, and so recommending that as a yes or no Boolean indicator. And as you can see, the spina bifida here at L5. Next. Caudal regression or caudal agenesis, dysgenesis, we recommend it as a highly recommended but not a core CDE. Next. So in the picture to the left, you see typical scoliosis, and we felt scoliosis should also be highly recommended. The picture in the middle shows a more mild scoliosis, and this child had presented with progressive scoliosis, a young male, which of course scoliosis is unusual. And then the picture on the right is after spinal cord untethering, about 8 weeks out. Next. Foot abnormalities, supplemental but highly recommended, because of course when we see children and babies with any of these foot abnormalities, then we consider tethered spinal cord. Next. So this lady actually saw about 4 months ago, and I saw her for Chiari symptoms, typical Chiari symptoms, headaches, problems with swallowing, dizziness, nausea, trouble with gait. And so she had a brain MRI that showed a Chiari, and I got the spine MRI just for the sake of completeness, looking for scoliosis, syrinx, or tethered cord. And then when I saw the film, she came back about 2 months later. I saw the film, and she has this thickening at the level that I have the line drawn. I can't point in this format, but at the level that the line is drawn, and her conus actually extended all the way down to the top of L3, L2-3, and then the axial at that same level, you see the conus low-lying, the phylum extremely thickened and pulled dorsally. So this is a tethered cord. And then I looked at her feet. It's 2 months later. Now it's summer. She's in flip-flops, and I saw the picture that you see. Wow. And so I asked her, and it turns out she'd always had a leg length discrepancy. Her mother had, asked many physicians when she was a child, what about her, legs not being the same length? And they just kept telling her, oh, that's just her. She's always had to buy shoes in 2 different sizes. The right foot is a full size, smaller than the other. And then you see the high arch. Next slide. The baby on the left is just showing a difference in leg size versus length. Next. And I thought those were most of the neurocutaneous and orthopedic findings that we wanted to include.
Holly, thanks very much. That was excellent. Is Miles Koby there for the radiology section? Could you go to the next slide? Miles? Yeah.
Let me just make sure he's unmuted. Yeah, hang on 1 second. There you go. Oh, there you go. Dr. Koby?
Miles, do you there?
Should be able to, it says you're connected to the audio.
Okay.
Do you want to take the first one while he's?
I'll just take, right, so for the radiological section, the first core was the conus medullaris position, and there are many permissible values for that, about a dozen. The next. And then the presence of the fatty phylum, it's a Boolean type, yes or no. Next. The position of next.
Do you have me at all now?
Now we have you.
Okay.
Yes.
Okay, I have changed.
You may have to turn off your cell phone.
I've changed headsets here. Okay. One of the desirable but supplemental is a widened spinal canal at the L5-S1 level. We can go to the next. Block vertebrae or congenital fused vertebrae. Segmentation abnormality may be useful. If we can go to the next. The width of the phylum terminale should be less than 1.2 or 1.2 millimeters. We can go to the next. That's the widened spinal canal at the lower level. Next. Next. Okay, come back. That's thickened, that's fatty infiltration, but also thickening of the phylum terminale. Another element, next, would be the variation of segmentation anomaly. Here we have lumbarization of S1 rather than fusion and incorporation above. This is a free sacrum as a lumbar segment. Next. This is demonstrating posterior placement, posterior and low position of the cord. So we're looking for tethering or retethering. Next. And here is a prone and supine MRI looking for cord movement or displacement in the prone and supine positions. Next. Okay, the other things would be desirable, but not necessarily proven entities, and they include sonography, high resolution sonography, and neonatal sonography. We can go to the next slide. And we can also demonstrate instability, which is in the lower right corner between a supine MRI and an upright MRI showing subluxation at L3, L4. Or dorsal adhesion, there's the cervical, there's different images of adhesions, whether they're post-traumatic or post-infectious. And transitional vertebrae on the upper right corner may also have value. That's all.
Okay, thanks, Miles. For the pathophysiology, there are very few core CDEs. One is the presence and the second is the characteristics next of the fatty phylum. Next. Go next. And we've go back. We've recommended. Go back. Okay, I think we're missing some. We've recommended a number of experimental CDEs looking at the collagen to elastin ratio of the phylum, the presence of thickened collagen, presence of mast cells and other inflammatory cells within the phylum, and they lie. We're recommending their inclusion as exploratory CDEs. Next. Urological findings, David Gordon
Yep,
and
I got it.
Singh from the Pelvic Neuroscience Institute.
Yeah.
Affiliated,
Yeah.
right, top notch.
So,
Okay.
Caitlin, can you unmute Dr. Singh also?
Yes, I thought I had.
I got it.
Yep,
There it is. Okay, good. So basically, let me Thank you very much. Let me just say, Dr. Singh and I are in the brain and spine unit at Sinai Hospital, and we are in the division of pelvic medicine and pelvic neuroscience up on the 3rd floor. We have a in addition to other things, obviously, we have a state-of-the-art urodynamics lab there, and most of our work before about 4 years ago was from neurologists and neurosurgeons in the institute who send us patients with different types of neuromuscular lower urinary tract dysfunction and MS, stroke, spinal cord injury, et cetera, et cetera, et cetera. Not a whole lot of tethered cord, although we would see an occasional patient of Claire Francomano because she was right down the street from us for a long time, but never anything that we could really put together with respect to tethered cord. And over the last, what would you say, like 4 years now, right?
Exactly.
That we've been working with Dr. Long, Dr. Henderson, Dr. Klinge. We've been able to, the lion's share by Dr. Henderson, amass probably over 250 urodynamic studies in patients with presumed tethered cord. Now, one of the issues is that there's no generally accepted pattern from a urodynamic perspective that neurosurgeons or even urologists can agree on. I think the pediatric urologists as a group have some tendencies, but even they are a little bit diffuse. Now, hopefully over the course of this next year, we're going to be able to show you some of our work with respect to specific patterns that may be very suggestive of tethered cord. But at this point, we're talking predominantly definitions for the CDEs, because it's difficult to talk about these things, especially after urodynamics, unless everybody is speaking the same language semantically. So today we're just going to go through some of the CDEs that we've put together. So I guess the domain is your. Can you see this? Do you see my my mouse? Do you see this?
Yeah.
Do you see it moving?
Is it?
Or
Yes.
no?
Yeah, we
Yep,
see
we
it.
see it. We see it.
Okay, good. All right. So I guess the domain is your dynamic studies, and the first CDE is detrusor sphincter dysinertia. And I included a little graphic here, but the definition is any disturbance of the normal coordination between bladder muscle contraction and the coordinated relaxation of the proximal urethral musculature and periurethral musculature during voiding. This can impair emptying secondary to bladder muscle contraction against an incomplete relaxed pelvic floor. And so the obviously the abbreviation is DSD, and you can see right here in this type of in the urodynamic in the EMG channel how you start to get as the bladder fills, you start to get increased pelvic floor tone, but as the patient approaches voiding, you get very discoordinated and impaired relaxation, making it hard to empty. Sometimes with concentration, these people can empty, but it can be very, very difficult to empty. This would be considered a non-hostile type, and in general, detrusor sphincter dysinertia would be considered predominantly non-hostile. The value type is Boolean, and list of permissive values to one core. Okay, so yeah, next slide. Great. Okay, so this CDE is detrusor external sphincter dysinertia. And let me go through the definition of this. Disturbance of the normal coordination between bladder muscle contraction and relaxation of the this allows for a simultaneous contraction. So it's a simultaneous contraction of both detrusor and urethral sphincters, predominantly the proximal portion of the external sphincter. So you have a closed bladder outlet against an active contraction. So this is a hostile event, and it's usually seen in lesions between the brainstem and the sacral spinal cord. So you can see very, very, very high detrusor pressure, spiking to almost sometimes over 100 centimeters of water, which cause so much pressure that you can actually start to see reflux. Usually it's unilateral reflux, and you start to see the formation of diverticula in the bladder, and sometimes you have urinary leakage. So this detrusor external sphincter dysinertia is a very, very high pressure hostile event. And again, the important thing is that this is usually it usually points to a spinal cord lesion between the brainstem and the sacral cord. Okay, next slide. So urinary frequency, probably the most common lower urinary tract symptom. According to the International Continence Society, it's the need to urinate more than 8 times in a 24-hour period. And it may be accompanied by an urgent sensation to void. Again, it's Boolean yes or no, and list of permissive values or 2, and there's our references. Next slide. Nocturia, again, is defined by the International Continence Society, the phenomenon of being woken from a sound sleep in order to urinate at least 1 time per night. It's often associated with an urgent sensation to void. Again, Boolean type yes or no, list of permissive values, core. Okay. Urinary urgency. This happens to be the core symptom of what people call overactive bladder today. And it's defined again by the International Continence Society as a sudden compelling desire to pass urine, difficult to defer, and often associated with emotional distress. That emotional distress that they talk about is the being on the cusp of being socially unacceptable by wetting your pants. So urinary urgency is the initiation of an involuntary motor contraction that if you would do urodynamics on these people, you'd be able to pick up. Next slide. Urinary hesitancy, difficulty to initiate, to begin the voiding cycle and or maintaining urine flow. Usually it's secondary to different types of associated pelvic floor hypertonicity. Next slide. Dysuria, the symptom of pain or burning during voiding and or pain or burning during the initiation of the of micturition. Next slide. Urinary tract infection, again, as per the International Continence Society, it's when microorganisms attach to the urothelial mucosa and invade the superficial layer, get into the submucosa, and begin to multiply, inciting an inflammatory response. Yes or no, permissible values. There's our reference. Next slide is pyuria, and pyuria is defined as 10 or more I think that it's 10 or more white blood cells. That's wrong. It's 10 or more white blood cells present in each cubic centimeter of urine sample.
That's correct. Yes, absolutely.
So we'll have to fix that. We'll fix that. Okay. Next slide. Calculated detrusor compliance. Okay, and this is just a standard calculation. Change in volume over change in pressure gives us detrusor compliance. There are the references. Next slide. Involuntary detrusor activity. So involuntary detrusor contractions. inappropriate aphasic increases in detrusor pressure greater than or equal to 15 centimeters of water that occur during the filling phase. Now, in a standard urodynamic curve, during the filling phase, there should be no involuntary detrusor muscle activity. So any activity greater than 15 centimeters of water pressure would be considered an IDC. Next slide. Intravesical pressure during filling. So that's the unsubtracted pressure within the bladder during the filling phase. Okay, next slide. Double voiding is incomplete bladder emptying requiring a second relaxation event of the voluntary external sphincter to allow for a second detrusor contraction in order to complete bladder emptying. And initial sensation to filling. This is, again, it's a Boolean yes or no. Normal sensation to filling would occur after 100 milliliters. Hypersensitivity usually occurs below 100 milliliters. CDE. Baseline filling pressure. Baseline filling pressure urodynamically should be less than 10 centimeters of water pressure. Awake capacity before pain or leakage. Ruth, you want to comment on this slide?
So certainly, right. Obviously, there's no, there's no standard number that we use, but most people with presumed tethered cord tend to have obviously quite large. They're able to fill up to 600, 700 cc's before they even feel that that the study should be stopped. So essentially, if we're filling somebody 700 cc's of bladder volume, that does really speak to the fact that obviously this is not normal. So we don't have a standard number for this, but normally numbers above 600 cc's are generally quite abnormal. We tend to see that quite often in patients who have diagnoses of tethered cord. Right.
Great. Thanks very much, David and Rupindra.